Good morning, ladies and gentlemen. My name is Hyo Cheol Kim. I'm an interventional radiologist. As you see, my email address is radioembolization because I'm a big fan of radioembolization. This is my disclosure. This is our hospital's data. Between 2011 and 2021, 610 patients with HCC received liver transplantation. At the end of 2022, 109 patients had recurrent HCC. And initial treatment modality for recurrent HCC included TACE in 39, resection of including lymph node and peritoneal seeding in 14, resection of lung in 12, external RT 14, ablation 3, systemic therapy 13, best supportive care 10. So you can imagine the pattern of recurrence after liver transplantation, and many patients have extrahepatic recurrences and very extensive recurrences. I will talk about these things. This paper came from China. Recurrence-free survival after surgical resection or ablation for recurrent tumor has a similar recurrence-free survival. And this is another paper from China. And as you see, the ablation for recurrent tumor has very good local tumor control rate, very few local recurrence. However, overall recurrence-free survival is very bad because of many patients had remote liver recurrence or extrahepatic recurrence. So I will show you one representative case. This patient has a small single tumor 3 years after LDLT. As you see, this is arterial phase CT, but tumor shows low attenuation, which means the tumor has very low tumor vascularity. So intraarterial therapy is not an option. Even though the tumor is aborting the hepatic vein, the ablation was performed. And immediate CT scan after ablation, you can see the tumor was well treated. And 1 year CT shows the tumor is well controlled. However, new region developed in the remote liver. Let's move on to TACE. This paper came from Assam Medical Center, and 28 patients received TACE for recurrent HCC. As you see, about 2/3 of patients has extrahepatic metastasis. About 2/3 of patients have a multiple intrahepatic recurrence. So the overall survival looks not so good. And this is a common situation. The patient has multiple tumors, and the TACE was performed, and 1 month CT after TACE shows that some tumors are well treated, and you can see accumulation of lipid, but you can see a lot of recurrent tumors. So overall objective response rate about 50%. So the poor tumor response of conventional TACE after a recurrent tumor is natural. And this is another paper from China. 14 patients received conventional TACE after liver transplantation, and you can see more than 70% of patients has multiple intrahepatic recurrence. About more than half of patients has extrahepatic metastasis as well as intrahepatic metastasis. So the overall survival looks very bad. I will show you one representative case from our hospital. This patient has 2 nodules and 2 years after LDLT. And we performed the super selective treatment like this. And 3 months CT shows the smaller one was well controlled by TACE. However, the larger tumor shows local recurrence, and you can also see a remote recurrence. So early recurrence or local recurrence is very common in TACE patients. Let's move on to radioembolization, and this paper came from America, and 22 patients were treated with Y90 in 3 major centers of USA. And 13 patients has a single tumor and 9 patients has multiple tumors. And you can see much better tumor response. A complete response rate was 45%. Overall objective response rate almost 70%. And median overall survival after Y90 was longer in single tumor than in multiple tumors. This is our case, and this patient has a 4 cm size, a single recurrent tumor 3 years after LDLT, and this tumor treated with radioembolization, and 1 year CT shows a complete response of the tumor. However, the lung metastasis and lymph node metastasis progressed, and the patient died of extrahepatic metastasis 1.5 years after radioembolization. So because of limited efficacy of local regional therapy, the combination therapy, TACE plus systemic agent may be promising. And indeed, this paper came from China, and combination therapy shows better overall survival than local regional therapy. And probably next speaker talk about this systemic treatment. And the summary of literature said multiple tumors are common after liver transplantation, and concurrent intrahepatic and extrahepatic recurrences are very common. And after local regional therapy, remote liver recurrence and extrahepatic progression is also common. So local regional therapy is effective in limited population. Patients are having localized tumors. Let's move on to the risk of complication. Cirrhotic liver has rich, enhanced peribiliary plexus. And so cirrhotic liver is resistant to ischemic injury by embolization. So the risk of liver abscess or biliary complication is relatively low. However, transplanted liver is a normal liver, very susceptible to embolization, ischemic injury by embolization. So some transplanted patients has biliary anterior anastomosis or biliary stent. The biliary stent or biliary anterior anastomosis much aggravate the risk of abscess or biliary complication after TACE. Even though we perform prophylactic antibiotics before the TACE, the risk of biliary complication is still very high. So if we do strong TACE means we infuse a lot of lip powder emulsion and gelatin sponge particles. The risk of biliary complication is much higher than in normal patients. So we are afraid of biliary complications. So we do weak TACE in transplanted patients. So because of weak TACE, the tumor response is generally much lower than normal patients. This patient had tumor recurrence 6 months after LDAT, and the first and second TACE after liver transplantation didn't have any complications. So you can see the large tumors are relatively well controlled by the first and second session TACE. However, CT scan shows multiple numerous recurrence after second session TACE, and you can also see a biliary stent here. So at the time of third session TACE, there are numerous tumors throughout the liver, and LOBA treatment was done, and you can see accumulation of lip powder throughout the liver. So 1 month CT shows liver abscess. This patient also had recurrent tumor 3 years after transplantation, and the patient was treated 4 sessions of conventional TACE. During the 4 sessions of conventional TACE, liver abscess didn't develop, and you can see larger tumor was well controlled by 4 sessions of conventional TACE. After that, you can see small marginal recurrent tumor and small remote liver recurrence. At the time of 5th session of TACE, small tumor was selectively treated, and 1 month CT shows liver abscess. So Regardless of tumor size, there is a high risk of liver abscess in patients in liver transplantation. Radioembolization has minimal embolic effect. So theoretically, radioembolization has pure biliary complication compared to TACE. So in conclusion, ablation has the same efficacy between transplantation patients versus non-transplantation patients. However, small single recurrent tumor is very rare. TACE has a decreased efficacy compared to normal cirrhotic patients because of multiple tumors, concurrent extrahepatic metastasis. Patients received immunosuppressive drugs, and we do weak TACE. We are afraid of biliary complication, and the patient have a high risk of biliary complication, even though antibiotic prophylaxis is applied. And radioembolization has excellent tumor response and fewer biliary complications. So single recurrent tumor or oligonodular recurrent tumor is a good indication for our radioembolization. Thank you for your attention.